In utero, everything is going smashingly, swimmingly. It's great. Mom's taking care of blood supply for baby, and you are getting oxygenated blood from the placenta delivered to the baby. So because mom is providing the oxygenation, what do we not care about? Where do we not need blood to circulate to? The lungs, very much the lungs, right? So, and parts of the heart too, we have some altered flow through the heart. And so mom's oxygenated blood supply comes into the inferior vena cava, and then it goes to the heart, but we have two important structures. The most important is you will have the ductus arteriosus, so that oxygenated blood comes back to right atria, right ventricle, but whenever it goes out the pulmonary artery on its way to the lungs, you have the ductus arteriosus, which immediately diverts a large amount of the blood supply directly into the aortic arch, and that bypasses the lungs and the left side of the heart. You also have your foramen ovale in between your two atria, so some of the blood also releases across the top of the atria out to the left side of the heart and then out through the aorta. So we are, of course, not sending much blood supply to the lungs. And then you are born. And we can all generally agree that things tend to go sideways as soon as that moment in time happens, right? So what are some of the things that start to change with the human heart the second a baby is born with normal circulation?
Foraminal valve closes.
Yeah, so over time that foraminal valve will start to close, absolutely. So that'll close. What else changes? You start breathing on your own, all right? So all of that blood that is now going out the pulmonary artery starts to fill as your lungs expand, and then you've all of a sudden got a lot more circulatory space for that blood to flow to. And so now your blood is flowing throughout your pulmonary vasculature and getting oxygenated, returning to the heart. And over the next couple weeks, what is the other thing that changes about the heart? The ductus arteriosus starts to close. So as they get increased arterial oxygenation, that will stimulate the closure of the ductus arteriosus. And for most of us, that works out just fine because we have normal circulation. But as we'll talk through some of the effects, if you were dependent on that ductus arteriosus to provide some level of circulation, you will get into a world of trouble in those first couple weeks. 2 to 4 weeks usually is when that starts to close. So you all had to learn this endlessly for paramedic and critical care, I'm sure, as we trace the drop of blood as it flows throughout your circulatory system. So your deoxygenated right atria, right ventricle, out through the pulmonary artery, lungs, returning via the pulmonary veins, ideally to the left atria, down to the left ventricle, and out through the aorta to circulation. So normal heart for the normies. So how frequent do congenital heart defects occur? They're super frequent. So about 1% of births have a CHD, and 25% of those have a critical congenital heart defect. That means that within the first year of life, they require surgical or cardiac cath intervention to fix or address part of their problem to help them survive their heart defect. So they are pretty common. If you will permit me some really basic math, but about 4 million births in the US every year, so we're talking about 40,000 patients are born with heart defects and 10,000 of those with critical heart defects. So a fairly common thing throughout our world. One thing that I added new to this lecture today, but I do think it's worth talking about and thinking about, the world has changed a lot with regards to CHDs, and that's because we know about a lot of them. I'll talk about prenatal screening here pretty shortly. But I do think it is always worth bearing in mind that in EMS, there are situations where we are not always blessed to be that well prepared. And there are situations where you can be dropped in and you might have the unknown CHD. In some ways, we're back to caveman days, or at least, the 1970s of you didn't always know what happened when somebody rolled through the door, and so you're trying to figure this out. So I just wanted to point out that there are some situations where you still will encounter a kid in a ton of distress, especially either after the initial birth or within that first 2 to 4 week period as that ductus arteriosus starts to close. So just situations that pop out to me on my home births where there maybe wasn't good follow-up care, and or pregnancies where there wasn't good prenatal care and definitely not ultrasounds done at 20 weeks. These are all situations where all of a sudden you start to have to think, like, if this kid is sicker than snot today, well, maybe there might be a CHD in play that was just never found or diagnosed at any point along the evaluation process. I picked on teenage pregnancies a little bit, but just to maybe speak to more of the category of the I didn't know I was pregnant. If you have no prenatal care, anything goes. Like you might not know what you're going to encounter that day with that kid, and so just to put it back on your radar screen to be aware of it. Home births, I did put an asterisk. I don't necessarily want to knock that. It's just a modern day trend, and a lot of those families and patients do still get proper prenatal care. They just have a preference for where they deliver their baby. But I am always reminded I was talking about heart defects in southern Missouri with one of our agencies down there, and they spoke to situations of like communes where they would just like have this whole village living off down the dirt road, and anytime they needed EMS, they'll say, hey, meet us at the mailbox up front and just come, hey, here's a sick kid, right? So there are situations, of course, in EMS where we can just get into, it could be anything, a bit of a Pandora's box, so. This is why it is increasingly rare. It's because of all the preventative care that we do. So cardiac ultrasound is often done around that 20-week mark, and they can identify a lot of different potential heart defects that are already formed and potentially coming with that kiddo. Also, we do much better CHD screening whenever we go to discharge the patients home now from the NICU. So we'll talk more about what that screening process is shortly. And then also, as I kind of let out with, but the increasing specialization of the tertiary care centers. You just have centers that are dedicated with cardiothoracic units that specialize in taking care of all of these different defects. And so that has really led to increased awareness and treatment planning for kids born with the heart defects. This is what that pre-post ductal SpO2 check is. This is all the CHD screening is. It's kind of awesome. It's super simple. There's not a ton of fancy machinery. You could actually do it on every one of your trucks today if you want. So they put pulse ox on the right hand or right wrist, and then you can put the other pulse ox on either foot, preferably after 24 hours of birth, because in the first 24 hours, those kids have lots of different cyanosis that they can exhibit. But after 24 hours, you run this test. And if there is a sustained difference of greater than 3% between the two pulse oxes, that is often indicative, or it can be indicative of a ductal dependent heart lesion. So I'm kind of flying through that real quick. Probably worth slowing down just a minute and talking about. So why is that? What is it about the ductal dependent lesion, the ductus arteriosus? Why does the pulse ox check tell me that that's there?
The right subclavian artery is before the ductal.
Perfect. So your blood supply to your right arm comes off of the aortic arch prior to the ductus arteriosus. So whatever blood's coming out of the left side of the heart is going over there first. But if you have the ductus arteriosus still intact there, the blood supply will be different down below as that starts to close off if they were dependent on that. So that's why it shows you their reliance on it. It is almost always that you have the right will be greater than the left. There is one condition, I jump ahead of myself. We'll talk about that when we get to, I got one of your kids at SCCAD here that has this condition. We'll talk about, there is one where it can reverse and go the opposite way, so. All right, so the heart defects. As I mentioned, we're not gonna do a slide by slide for each and every one of these. But these, of course, are a lot of the major heart defects that are available, and I have broken them up to you by acyanotic and cyanotic heart lesions. So very simply, what is the problem in an acyanotic heart lesion? So what is the challenge for a patient with an acyanotic heart lesion? They don't show. Perfect. So so these are pink problems. All right, and so what is the issue? Whatever their heart defect is, whether it's a hole in the heart, whether it's plumbing, crisscrossed and going to the wrong side, but their issue is that they are properly circulating their blood through the right side of their heart. It is oxygenating in the lungs and getting the left side of the heart, but some of that blood is being recirculated back to right. So it is a left to right shunt. So the blood is getting plenty of oxygen. The challenge in these heart problems is that it's getting over-circulated back to the right side. What does that cause to happen? If you're making the pump work double time, There you go, hypertrophy of the right muscle. So as you make that right side's like, man, we already were pumping the perfect stroke volume each and every time, and now you're adding extra on top of that. So it starts to Schwarzenegger out, it starts to get thicker and stronger as it has to deal with pumping extra blood every second or so in your life. And so you will start to get right ventricular hypertrophy, which will eventually lead to congestive heart failure as that muscle gets weaker and weaker on that right side. So acyanotic heart lesions, like you said, it doesn't look the same. We don't get the hypoxia and all the blue, but over time, those patients can get into congestive heart failure style problems. Versus the cyanotic heart lesions are over here. So what is their major problem? Hypoxia, absolutely. So their problem is that they are getting blood from the right side of the cardiac system. During the pump or the systole, it is going to the left side without going through the lungs. And so it does not get oxygenated. So their issues and challenges are all related to hypoxia and cyanosis. Often referred to as either the 5 or the 6 T's to remember the cyanotic heart lesions. And if you use the 6, all it stands for is tons of other things. So, there you go. So truncus arteriosus, where the pulmonary artery and the aorta are just combined as a single vessel going up and out. Transposition of the greater vessels, where the pulmonary artery and the aorta got switched. Tetralogy of flow we'll talk about shortly, but if you've had to take a critical care exam, you probably already know it because they love to ask the questions about the 4 components of TET. Total anomalous pulmonary venous return. Your pulmonary veins don't come back to the left atria. They go back to somewhere else and cause recirculation over on the right side. Tricuspid atresia. This occasionally used to be called hypoplastic right heart syndrome, but if you go talk to the cardiology people, they say there's no such thing as tricuspid atresia, so just to kind of put that out there in the ether. Pulmonary atresia, and then hypoplastic left heart and Ebstein's, which we'll talk about hypoplastic a lot in this lecture coming up. So those are just some ways to kind of remember them. So if you're on a T, if you show up and they say, we got a heart defect and it starts with a T, odds are you're on the left side of this, or on the right side of this, which is a left-sided problem. I did want to briefly circle back. So not all of these are ductal dependent problems. So I did put asterisks next to the ones that are. And you can have ductal dependent problems on both acyanotic and cyanotic. Why? Because some of the heart defects require you to have the ductus arteriosus in order to be able to get blood, oxygenated blood out to circulation. Other ones require the ductus arteriosus to remain intact and patent so that you can get blood supply from the aorta to flow back into the lungs to maintain oxygenation in the pulmonary system. So ductal dependent lesions, as we mentioned, the arteriosus starts to close at 2 to 4 weeks. And is often stimulated by increased oxygenation of the kiddo. Actually, part of the reason why we don't automatically want to blast sick little neonates with tons of oxygen unless they truly need it for respiratory problems, because you will start to cause other changes to happen in their physiology. So certainly if you have a sick hypoxic kid who needs oxygen, I'll never tell you to withhold it, but we don't want to blindly just be throwing that oxygen at our patients anymore. I think we understand that pretty well from a couple of different areas of our practice. And so, as I said, the left-sided heart defects require the DA to remain intact so they can have systemic circulation, and right side so that they can still circulate to the lungs. So this is a bit of one of the old boogeymen. So what would you do, right? This is you can tell what scared old ED docs because they talk about this and they're like, this kid came in out of nowhere, they were 3 weeks old, they were crashing on me, I didn't know if they were sick, septic. And then we had some reason to believe that they were sick because their ductus arteriosus was closing. What is the drug treatment of choice? Prostaglandins, 100%. So this is prostaglandin. It typically, I think transport team still gives it sometimes to talk about the critical care component, but a lot of this is managed at the NICU level depending on time to treatment. So I did put the dosing in there just in case anybody asked me, but it is started, and that will hopefully help stent and maintain that the ductus arteriosus open so we can maintain the flow until we can go render a cardiac intervention, either a cath or a surgery to fix whatever the problem is. The side effect of prostaglandin that you have to watch out for is it does cause apnea, so close eyes on the patient and making sure that they're still adequately breathing for themselves. All right, so to kind of dive into an example of each type of heart defect and the challenges that it causes in your patients, on the acyanotic side, I chose ventricular septal defect, and that is just because it is one of the most common diagnosed in infancy. There's a couple other, like where it's just valvular changes, are actually the highest percentage of CHDs, but those don't necessarily cause problems and they don't present, and sometimes they don't find those till much later in life. So the ones that actually affect the kiddos, VSD is one of the most common ones. You can see 4 per 10,000 live births there. So what is the challenge for these kids? So they were just born with a large hole between the two ventricles, and you can see a lot of times, so which pumps harder? Your left ventricle or your right ventricle? It's your left, of course, right? Because it's got to go out to systemic perfusion versus your right's only trying to pump a couple inches away to your lungs. And so a lot of times that left ventricle will just continuously overpower the right ventricle and the blood supply, and so it will leak oxygenated blood across the VSD, and then it will just recirculate again through the lungs on its way through. That causes the left to right shunt. So similar to if an atrial septal defect or the other atrial septal defect, which is a patent foramen of valve. So if it doesn't close between the two atria, you'll still have a hole. But VSDs can be much larger, and so therefore they tend to have a lot more complications for those kiddos. Will lead to eventually to pulmonary edema, pulmonary hypertension, and eventual heart failure. At the very end of heart failure, they can start to go the other way, and so they'll start to get a right to left shunt, but that is in stages. So I've always I chuckled a bit, I don't know if that's professional, but when you go through PALS, right, there's a couple cardiac scenarios in PALS. Do you guys remember it? You get a tiny little infant and they present to you and they aren't taking a bottle and they're crying and they're irritable. And I only chuckle because that looks like every other sick type of infant you can ever get in any kind of pathology. It's like, oh, by the way, you should pick up on the fact that this kid's heart doesn't work right. Like, that's a true challenge to kind of keep it on there in the list of differentials. But I think, as we'll talk about for some other reasons, decreased growth should be another thing that kind of comes with that. So mom and dad say, so he hasn't been taking a bottle today, but he also just hasn't been feeding well in general, or even if he's feeding well, is not gaining weight. So failure to thrive is a common problem that we tend to see in the heart defect kiddos. And then irritability, that excessive sweating. So those can all be kind of indicative of that kid who's struggling with increasing heart failure symptoms. Whoops. So that's an example of the acyanotic. So that kid will present to you as pink, but they will be struggling to gain weight. They will potentially start to show you signs of right-sided heart failure, which we'll talk about with another scenario coming up. Versus now we're going to slide over and give you an example of that cyanotic heart lesion. And the most common cyanotic heart lesion is tetralogy of Fallot. For 2.5 gold stars for anybody who had to take the test. What are the 4 components of TET? Overriding overarching aorta or overriding aorta, absolutely. Pulmonary stenosis or pulmonary atresia? VSD. Hypertrophy, perfect. Got it. That, of course, is the normal heart, but as you mentioned, you got them all. So the way I always start, it starts with the pulmonary stenosis. So your pulmonary valve is where, of course, your blood goes out to leave to go to your lungs, but if that is stenotic or atresic, it never formed, or it's really stiff, it doesn't work well, that causes a lot of resistance. And so that's where I always think, that's where the hypertrophy comes from. It's because this right-sided heart's been trying for a while to try and pump blood against resistance. And so that's part of where that comes from. They have the VSD as well. And the aorta does kind of shift over and it sits over the top of the VSD. So you're getting that continuous mix of deoxygenated and oxygenated blood with each beat of this kiddo's heart mixing together and then going out to systemic circulation. And so that's what makes it a cyanotic heart lesion. Classically, this is one that comes with radiography. It has a boot-shaped heart is what you will sometimes get tested on if you are a person who looks at the x-rays. I always think of it, this is another one of the old boogeymen, where they used to say kids in TET spells, and these kids would come in, and if we were to use not TET spells, but the more medically accurate name, hypercyanotic spells. So there's actually not exactly a known reason why these kids will really clamp down on that pulmonary stenosis side. There's actually some thoughts that it might be a spasm in that area around the right ventricular outflow tract. But these kids, especially it's young kids like 3 to 6 months of age are the most common ones who will have the TET spells if they have tetralogy of flow. They get upset, they start to bear down, whatever the issue is, and they will start to really clamp down on that pulmonary artery, and they'll get even less blood flow to the lungs, and so they'll turn blue. And so these used to be referred to commonly as TET spells. The blood that does get out is mixing more and more of right ventricle is just going straight out through the aorta again because it's not going throughout the pulmonary valve, and so it will be deoxygenated blood that's getting out. The kid will turn blue on you. This did used to kill kids. It still does presumably kill kids. I'm going to talk about why I'm speaking in it a little bit past tense here in just a second. But this used to be one where if you could not get the kid to stop going through this cycle and making themselves worse and worse and worse, they would eventually get too hypoxic and they would crash and unfortunately die on you. So some things you can do just real basic maneuvers, do the knee to chest position to see if you can't increase some venous return back to the heart and systemic vascular resistance. You can do a little bit of oxygen, but you don't necessarily we've all had that fun life experience of trying to put oxygen on a little kid that didn't want oxygen put on them, and I think we all think the same thing, like this is stupid, right? Like you're trying to do it and they're just screaming and crying harder, and you're like, what? So first of all, document that, because a screaming crying kid is an excellent kid to be looking at. But also, if you make this particular kid cry more, it won't necessarily work. Sometimes you just got to get them to chill out. Like just calm down, stop doing whatever the aggravating feature is that is causing you to turn blue. One of my favorite protocols I learned about, actually Dr. Siegler taught me this one, at Children's, especially for unrepaired TET kids who come in who are in the middle of a TET spell, they'll just pop them with 25 mics of fentanyl intranasally, just like chill out, like just calm down, please stop doing whatever this thing is that you're doing. All right, so the reason why I kind of talk about it a little bit past tense is like a couple of the other CHDs, we do a ton of work to repair these kids before they go home nowadays. So there's a big difference between whether you're looking there at an unrepaired TET where they potentially could be having TET spells, but a lot of times we have done some sort of patch or some sort of procedure to try and restore blood flow for them. And so for instance, this is a temporary shunt that they'll do. They'll do a Blalock-Taussig shunt, which we're about to talk about a whole lot as we go through hypoplastic left. But it is a little Gore-Tex shunt that they connect between the aorta back to the pulmonary arteries to restore basically an artificial ductus arteriosus so that you get some blood to recirculate back from the left side to go through the lungs again to make sure it's getting oxygen. And so they'll do that. And then eventually there's a longer term repair where they'll come in and kind of, they'll close up the VSD if it's large, and then they'll kind of try to get rid of or remove some of that stenosis so that it's easier for the kid to get blood flow up and out of their pulmonary artery. So this adds one of the complicating features of this talk, but I think it's worth talking about. It's not as simple as saying like, oh, you were born with your arteries going this way or a hole in your heart this way, and then therefore this is the treatment I'm going to do. Like many of our other complicated patients, we look at them and we say, what has already been done for you and what else could be going wrong with that surgery or that device or that thing that's going on with them. So for instance, if you had a kid who's got this temporary shunt operation, they shouldn't be prone to TET spells. Like we took care of that. The blood flows a different way through the lungs. So if they're all of a sudden crumping and crashing in front of you, this kid was normal 30 minutes ago according to mom and dad, came in, wasn't feeling well, and now they look like they are crashing in on death's door. What is something you've got to add to your list of differentials?
Any complication from surgery?
Yeah, and very specifically, there's one here. So we put an artificial vessel in their heart. So sepsis if we're near the surgery, but where I'm going, I'm sorry? Clots, absolutely. So especially this is why the heart kids, whether it's because of their natural anatomy or because of the devices we put in them, take aspirin each and every day, is to make sure that we have we lower the risk of clotting of thrombosis in there. So it does have to be on your list of if they are dependent on some sort of shunt, cardiac shunt that we've added for them, and all of a sudden they're crumping, it could be that it's clotted off. Now, what you're going to do about that is still a matter of some debate. There's a lot of, it depends on where you are and whether it can be figured out if that's what happened. Unfortunately, a lot of times these kids show up in full arrest and expire. But there are some instances of, being able to check, cardiology goes in, checks forward flow, says something's wrong with the shunt's not flowing well, and then they'll immediately ECMO and go in and try to fix something, so. All right. Hypoplastic left heart. So slightly rarer than TETs, but I like talking about this one because I think it is very illustrative of a lot of the topics that are in the rest of these slides. So you can see about 2 to 3 per 10,000 births. Now that's a little bit misleading because that's a nationwide stat, but there are certain pools of the US where you're more likely to encounter this than others, not because the population's any different, but because you have the specialists to treat it. So commonly what you'll see is tertiary centers that are really good at this, and we happen to have 2 of them here in St. Louis because we have some of the early cardiothoracic surgeons who worked on this. So you will, even though that seems like a relatively low number, your odds do increase depending on where you are geographically. And I think actually, I'm going to show you some of SCCAD's numbers later. I think it speaks to it a little bit because you guys have 7 hypoplastic left heart kids living out here in St. Charles County. Excellent. I'm so glad you brought that up. I'm hoping to touch on that later, but if I forget to mention adult CHD, please remind me at the end of this lecture because we got a few talking points on that one too. All right, so hypoplastic left heart syndrome. You were born without one working ventricle. You were born with a single ventricle syndrome. That's a bit of a problem, right? So if you guys will forgive me doing artwork, I'm so sorry that you have to witness this. But right, so in a perfect world, same stroke volume across all my chambers, except I'm born with a weak little, that didn't even do it justice. Yeah, they were born with a weak little left ventricle, right? That is a major problem. So that is a heart, young lady. How could you not tell? God bless. I'm going to give you this clicker, young lady. All right, so, yeah, listen, Texas public schools, okay? What did you expect? All right. All right, left ventricle. So that you're born without one good working ventricle. That is a major problem. This used to practically be a death sentence. So up until like the early 90s, this had a 90% mortality rate. In fact, the only way you could survive it is if you were also born with another heart defect that allowed you to have some sort of forward flow to get circulation out to the system. Because otherwise, the moment your ductus arteriosus closed off, there was no way to get blood from the right side of the heart out to systemic circulation and have it be oxygenated. It was a death sentence. So how would you fix that? What comes to mind immediately? Like, what should we do for a patient born with one working ventricle?
Increase blood flow somehow, or
Absolutely. Yeah, you're already working on troubleshooting it, which I appreciate. A lot of times, sometimes in talks, people are like, well, they just need a heart transplant, right? Like, they were born with a bad heart, they need a heart transplant. The issue, of course, is that we don't have nearly enough not a lot of spare baby hearts. So that wasn't a viable option. So the cool thing about this is there was a group of surgeons in Children's Hospital of Philadelphia at CHOP who figured out a surgical technique to be able to try and salvage the patient's anatomy so that they could have blood flow with the heart that they were born with for the rest of their life. So it's a super cool thing. It takes a set of surgeries. So we're gonna kind of talk through it, but a lot of times I think you guys already be there, right? So you were born with one working pump. So what do we have to do?
Make 2 pumps.
Oh, I wish we could.
You gotta create a DSD
That's exactly where it is. So we take your one and only working ventricle. We're not even going to call them left and right for very much longer in this talk. You have one working ventricle for systemic perfusion for the rest of your life. So for the first surgery, which is called the Norwood, we are going to switch your aorta. Replace your pulmonary artery so that when your right ventricle pumps, that blood flow goes out to the system. And then so that's cool, that's awesome. It's really neat that they figured that out. What's the problem? What was the right ventricle doing for me? It was priming the lungs, right? Like it was making sure I had some circulation to go through the lungs is what its basic function of the right ventricle is. I just lost that. We got rid of it. We switched that to being the primary pump for the whole body. So now what we have to do is figure out, so how are we going to get blood back to the lungs? And we have to do a set of surgeries to do this. Why? Because infants are hard and challenging and complicated. And in this way, what they're complicated in is when they're born and for the first few months of their life, they have increased pulmonary vascular resistance. They have higher pressures in their lungs. So we can't depend on getting passive flow back to the lungs from the system. So we're like, okay, we got to figure out just how to have some circulation. So what they did is they said, all right, we switch the aorta over to the one and only working ventricle, and then we're now going to make sure that some blood flow, because right now I don't have a pulmonary artery. I don't have any way for blood to get pumped to the lungs. That's where they come in and they put that Blalock-Taussig shunt off of the aorta. It circles back to the pulmonary arteries, and now with each beat of the heart, some blood is getting pushed back in through the lungs so that it can get oxygenated. That blood, of course, returns to the left atria, which has nowhere to go. Reference amazing picture before. Nowhere for it to go. All right, so what they do is they cut a hole between the two atria so that all the blood coming back to the left atria actually goes to the single atria now, and it goes to the single ventricle and it goes out to circulation. We took a 4-cycle engine and we turned it into a 2-cycle engine. And that's how this patient's going to maintain some blood flow. This is incredibly palliative. This is just so you didn't die as soon as the ductus arteriosus closed off. We gave you an artificial ductus arteriosus, but these kids are at high risk. These are the kids that sat incredibly low. So when you're reading a plan that says this kid only sats, 70 to 85%, are those kids, because they are just mixing so much deoxygenated and oxygenated blood with each beat of their heart. And as you might imagine, it saves them, but not a lot of blood flow is going through that BT shunt to get a whole lot reoxygenated as they go through their cardiac minute cycle. So this is what we do just initially to get them through what's called the Norwood. For any of you who've already, I assume everybody in here's tested critical care, if you're already in this class. So you probably remember, they love to ask about these 3 on there too. So these are the 3 major heart surgeries that are done for the single ventricle kids. So you have the Norwood is the first one just to keep them alive. Then at about 2 to 6 months of age, they'll come in and do the Glenn or the Hemi-Fontan. I prefer it by its second name, which is the Hemi-Fontan, because it makes it really easy to remember what it does. And then finally, after about 2 to 5 years of age, when that kid is big enough, they will come in and they'll do the Fontan. As you can see, we still are at high risk here, so only about 60 to 70% survival rate after the Norwood. However, after we get you to the Glenn and the Fontan, the survival rates are very significantly higher once we reach that point. I talk about the Blalock-Taussig shunt because that was the OG or one of the originals, but there is another group that, or another school of thought that is doing the Sano shunt instead. So instead of doing a shunt up here from the aorta to the pulmonary arteries, they just basically artificially created a pulmonary artery. They take a Gore-Tex shunt, they directly cut a hole in the one and only working ventricle, the right ventricle, run that up to the pulmonary artery, they disconnect the pulmonary artery, and they just create an artificial pulmonary artery. So, I mean, let's be honest, the cardiothoracic people are kind of wizards. Like, they're just like, oh, I want blood to flow here. Let me just do this simple little thing, like cut a hole in a heart and put a tube to go somewhere else. So the Sano shunt, it's a little bit unclear. To speak a little bit to this and the adult CHD question, we don't know all the answers yet. Like, we just started doing this in the 90s, so they're still testing like what is long-term outcomes for these patients and which ones are best for them. And so there is at least some indication that the Sano shunt might have less long-term complications. All right. A lot of patients are going home after they have the Norwood surgery. And that's a little bit different from years gone by or years previously where we used to just keep these kids in the hospital until we got them through a lot of their stuff. But we do send kids home to heal at home now, to be with their families at home. So you will see a kid who gets the Norwood in the first couple weeks of life, stabilize out over a couple weeks or a month at the Children's Hospital, and then get sent home. They often go home on oxygen, right? So these families will have a plan that says, hey, this kid, your kid, have a pulse oximeter, check them every now and then. If they are less than 70 or 75%, put them on a liter or two nasal cannula. If you recheck in 5 minutes and they are still low, call 911 and contact your surgery team, and you need to come back in. So in many ways, these parents will have instructions that read like your protocols for what to do, and it's a very valid reason why you might go run on one of these kids. The other new thing, a lot of these kids are going home on digoxin for their inter-surgery period before the Glenn. If they are having issues with fluid retention, they'll be on Lasix when they go home. You might see things like enalapril, albeit kind of the latest studies are like showing that maybe the ACE inhibitors aren't necessary for every heart, only the ones who are truly having a lot of complications. And so we'll send them home, and you gotta assess them for distress, you gotta assess them for heart failure, but that looks a little different in the kids, and I got a good example of that coming up. Part of checking them for distress is what I mentioned earlier of the failure to thrive component. Like, you really wanna ask mom and dad about intake, output, so the classic, like, we learn all this advanced medicine and it turns out a lot of the basics are just like, are you eating and are you voiding? And so we can put those two pieces together. And are they happening at equal levels? And so same thing with these kids. So when mom and dad go home with these kids, they're doing frequent weight checks. It used to be home health nursing that was sent out there to do it. But as we have all seen, there's often a dearth of home health nursing depending on where you are in the world. And so this is one where we've once again turned the parents kind of into the caregivers. And so that is something you might see. I actually, slight aside, but I think a huge future or potential option for community paramedic as a way we can go check out on post-surgical patients and do a basic home check for patients who are really brittle on oxygenation and need frequent weight checks. So definitely a part of the world that I think will come in. And the weight can go wrong in both ways, right? So if they suddenly have rapid weight gain, what are we concerned about in this little heart patient? Retention, absolutely. Classic heart failure, just like your older patients. And if they are losing weight, that is also a problem. Why are they losing weight? Absolutely. So they're not perfusing well. And how about if I come at it this way? What's the major way you and I burn calories? Caffeine plus exercise in my world. So yes, absolutely. Exercise, our big muscle groups, or like our skeletal muscle groups that move us around each and every day. How about my brand new little 2-week-old baby that's just sitting there laying in a NICU bed? How are they burning?
Heart is working away.
The heart, but more specifically, the biggest muscle group in their body that's moving, their diaphragm. So if they are in distress from being hypoxic and from not having good heart perfusion and they are just sitting there tachypnic, breathing away, they will burn extra calories that way, and that's why these kids will struggle to gain weight a lot, because they're burning faster that way. So that's another way that we check for that. So hopefully we've successfully gotten them through that inner stage period, and about 2 to 9 months of age, we'll come in and do the Glenn procedure, or what is its preferred name for me? The Hemi-Fontan, only because it helps it make a ton of sense. All right, so now we're going to get to start to do what we wanted to do in the beginning. We said we only have one working ventricle. We got to use that for systemic perfusion. We would really love to get blood back directly to the lungs. Just passively bring it back from my vena cavas straight to the lungs to be oxygenated before it goes to the 2-cycle pump to go back out to perfusion. I'm going to do the first half of it, the first half of the Fontan in the surgery. So what do? They come in, they take out the blalotoxic shunt because we're not going to need it anymore. They disconnect the superior vena cava coming back to the heart and directly attach it to one of the pulmonary arteries. And so now the superior blood circulation returning into the heart actually just goes straight to the lungs and will get oxygenated. As you can imagine, there is a lot higher percentage of the systemic circulation now returning to the lungs, so these kids tend to sat a whole lot better unless they had other problems, and so these kids will be much closer to the 85 to 90%. They might even get up to 95, pretty high sats up there. And as we mentioned on the previous slide, much better survival rates once you get through the Glenn surgery. And now we get to do the full Fontan finally at about 2 to 5 years of age. They will come in and now they will disconnect the inferior vena cava. They will take it to the pulmonary artery, and now all of this kid's venous return just comes passively straight to the pulmonary arteries to the lungs to be oxygenated. There's a fancy little thing. It kind of depends on the cardiothoracic team apparently, but they will do a small fenestration sometimes off the inferior, just basically cutting a hole in the right, or the working ventricle, the right ventricle, as like a pressure relief pop-off valve. So fixed for these hypoplastic lefts, often. A lot of times these kids, if that was their only heart defect and their only problem, these kids often do pretty well. Ways I always think of that, like you can tell because you'll read in whether they have exertion limitations. Can this kid do full PE, or do they have instructions for, hey, if he's starting to get winded, should he sit down to the side? Do they have continued oxygen requirements at home? Are mom and dad still keeping O2 bottles and have instructions to check O2 or not? Are they still on medications? Almost regardless of the heart name, of the Latin name, of whatever's wrong with that heart, I can almost always tell you how sick that kid is just based on what's there in the home with that kid. So if you go there, you show up to a house for a 7-month-old, and you say, okay, what's going on? And they're like, oh, we had a cardiac cath, or we had a surgery. You're okay, when's your next follow-up? And they say, our next follow-up, that we follow up every 6 months, we're an echo. Are you guys on meds? Yeah, we take aspirin every day, nothing else. You guys have oxygen here in the house? We don't, or if we do, it sits in the back closet and we've never used it. That kid's heart is fine. Like whatever they did is probably pretty good for that heart. If you show up and they're still on Lasix, digoxin, enalapril, their aspirin, if they have planned, they say, hey, we're supposed to go back every 3 months for an echo, we potentially have a cardiac cath on the horizon, they start to tell you stories like that. That is a kid who still has a really sick heart that does not function optimally, and so that can kind of lead you to, like, if a kid's sicker than snot, is this still the heart being the problem, or have we got another problem at play today? So continued sick heart, the signs of those overload. I do have the scenario coming up where we'll talk about how right-sided heart failure tends to look in the kids. Some of the kids who are truly long-term problems, they start to resemble some of your older adults. Like they'll start to get varices backing up to the esophagus, or especially like say to the portal vein back into the liver, so they'll get that liver distension. There's actually a couple procedures where, I mean, they'll start to go into liver failure if they're in congestion too long in combination with it. So for some of those kids, they'll start to do like procedures to try and relieve the pressure on the liver as well. So connecting the pulmonary vein and the pulmonary artery to try and pressure pop-off valve, that might be the other name for this lecture. We'll put it in as a subtitle. All right, so to try and relieve some of that backup pressure though. And there are still a few handful of candidates who make it through. We do all this work for them, but ultimately they just do not have enough intrinsic heart function to survive, and so we'll augment it as long as we can and look for heart transplants for those kids. But at least the beautiful thing is now, I mean, we got a huge number of candidates through without needing the heart transplant, and we can reserve the few hearts that we do have for the ones who truly need it because they have poor ejection fractions and stuff like that. All right, so let's see if we can't put a little bit of this at play. It's not a pure case because it actually mixes a few of the things, but this is a real life STARS call that happened and some value to it from that. So we have a 4-year-old female. The EMS arrived to find her being held by mom. She was on a nasal cannula. Of course, we had a language barrier at play because we like to keep things easy in pre-hospital. And so mom wasn't able to communicate super well right off the bat, but she seemed pretty calm and collected. She walked out and met him. She was just holding a kid. And this is what EMS found. So they noticed cyanosis of the lips. Her fingers were also cyanotic. They noticed swelliness and puffiness around both of the eyes. There was no real redness, nothing else appeared to be going on with the skin. Cap refill time was brisk. They did note emesis, and mom was kind of able to explain like, hey, we've been having nausea, vomiting, diarrhea for a couple of days. These are the vital signs that they got. So BP 90/40, heart rate of 156, respers of 28, satting 77%. Lung sounds were decreased in the bases, and there was some right upper quadrant abdominal swelling. Which one of those vital signs do we really not like? SpO2 is enough to give you the weebie-jeebies unless we are able to find out if that is more normal for her. So this was straight out of her STARS plan. So she is a kid who was in the middle repairs, but also had a long history of DSATs and poor SATs. So the goal was just to keep her greater than 75%. And she is the tricuspid atresia. I'm not allowed to call it right hypoplastic anymore, but the same style problem. She wasn't born with a good working right ventricle, and so everything is off the left ventricle. So I think this kid's presentation makes more sense though now, right? Like this is what right-sided heart failure can look like in the kids. And it makes more sense, right? So you guys have run more adult CHFers than you ever want to in your life. Where do they back up to? Their legs, right? Dependent edema. Why? Because Old Man River's been sitting in the same lazy boy for a week straight, and gravity's been pulling all of that edema down to his legs. But no, never. All right, so my kids don't sit in lazy boys though, and they lay in different positions. And so if they're in car seats with their back down, or they're laying in cribs with their head down, the dependent edema goes elsewhere. So especially if they sleep head down, they'll get a lot of swelling to this loose vascular tissue around their eyes, so swelling, facial puffiness, and edema. If their back is down, they'll swell to their lower back. You'll get pitting edema in the lower back down there. One of the first places it backs up to is the liver, out of the inferior vena cava into the portal vein. So in a normal kid, the liver should be kind of right in line with the right costal margin, maybe a centimeter below it. But if you're feeling like a swollen, distended organ in the right upper quadrant in a cardiac kid, like that is a distended liver until proven otherwise. So that's something where you could be like, oh, I think this kid is backing up. They do also get back up into the jugular venous distension. They'll get JVD. It's just sometimes you get a fat little kid with a neck. It's kind of harder to appreciate like the JVD if it's there. And also, I mean, not a huge knock on us, but like it turns out the technical way to assess JVD is a 45-degree angle for a couple minutes and strip the vein and see if it refills. And I don't see that happening in the back of our rigs a whole lot out there. And so I know. I think if you heard this little girl's story, it 100% marches out with everything you've dealt with in adults, though. She had been to cardiology the week before. They had cut her Lasix dose. And sure enough, by the time we got to the weekend, she had started to back up. She came into the ED. They re-upped her Lasix to the dose she was previously at, and it all went away. So still kind of to speak to that, how do we fix it? It's the same. Now we took Lasix off of all our trucks, so of course I managed to find a way to be like, hey, we could put it back on. I got this one group of patients who might need it, but how about we not walk that road? It will fix it at the ED. It's just oxygen supplementation until we can get them there, circulatory supplementation. Assessment, just, for these kids, just to kind of follow our usual algorithms, but just, I mean, of course we're gonna assess to make sure we got a patent airway. They can be very tachypnic at baseline for some of those reasons that we talked about. So knowing what their normal respiratory rate is and whether they're above and beyond their normal is important. These kids can be pale or cyanotic or hypoxic at baseline, but that is not automatic. So asking family, like, hey, is it normal for them to have that presentation or not, can be really huge. Knowing whether a cap refill is normal for them or not. Disability, of course, can be very challenging when we're talking about weeks old and months old of knowing, like, are we at normal baseline or not with a sick kid? But trying to establish with family of whether we have altered mental status, asking them the questions, and remembering to check a sugar is super important in these kids because that diaphragm is just breathing away and they will chew through their sugar stores. And then you want to include temperature in your vital signs as well because it's another stressor that they'll get into as well. So continuous monitoring goes kind of without saying, EKG monitoring, SpO2, end tidal. Oxygen as appropriate. Like I said in the beginning, like I'll never tell you to withhold oxygen from a kid who's in true respiratory distress. Like sometimes we just got to support that. Just we don't want to blindly treat the SpO2 by blasting a kid with high flow oxygen. It will actually make it harder over 45 to 60 minutes. Oxygen is a pulmonary vasodilator. so it'll start to relax the vasculature in the lungs. So in the middle of a pump that we just said isn't working very well, you're now creating a bigger and bigger pool of blood in the middle, and they'll start to leak across the capillary beds, and you'll get pulmonary edema. So just never, what you want to stop is like, if your partner's like, he's satting 76%, I can't stand to look at that. I treat all patients with high flow oxygen because they sat that. If the kid is otherwise acting their normal baseline, just know that's okay. This kid is just, keep them above 75% and it'll be okay. We don't want to harm them with unnecessary oxygen during a lung transport.
Oxygen tank and just.
Yeah. Yeah. It's funny, I had maybe Dr. Finney, not to expand into too many other topics, but like, I say continuous SpO2 because we're EMS and we have one patient and we can watch them. But like in the ED, like it's becoming more and more like, do not leave them on the pulse ox because inevitably like somebody's going to want to put them on high flow because they have a transient drop, and just, you got to know your tools, right? And how pulse ox is useful for spot checks and knowing when you're going to treat based off of it, but maybe not blindly following pulse ox all the time. Oxygen as appropriate, the temperature management, and then just in a perfect world, I mean, if you have a sick cardiac kid, of course, the goal, like all sick patients, is to have 2 lines of access, one for meds, one for fluid resus as necessary. To kind of blend the couple different topics, there's a little bit of a difference between you're running a STARS patient or somebody well-known in your community who's a little bit older versus you're doing an emergent transfer for a kid who was just born who's in a world of distress. So that, of course, UVC access is one that starts to pop in there if appropriately, if it's within your scope and training. I did want to just briefly mention Stable, where I got some of these other treatment things from. So Stable, of course, is the kind of the pre-hospital or emergency department aimed. What do we do for brand new infants born who are in distress? And there is a cardiac version of that just kind of emphasizes a lot of these components, but the same idea, checking and treating sugars, making sure we're trying to get back to normothermic to take extra stressors away from that patient and their physiology, establish our airway, maintain appropriate blood pressure support, lab work as necessary, or something that might be done if you're doing an interfacility transfer from out here down to one of the children's hospitals. The last one is emotional support, that in Stable is aimed a little bit more at, you have a brand new set of parents who all of a sudden just got their world rocked with, we might have medical complexity and their world, all kinds of things changing. But I did want to take that just a little bit further in that I think that's actually super applicable to all of your medically complex patients, all of your patients, but I get to support the medically complex ones. This slide is a bit of an homage to my predecessor, Trish. She created it, but I do think it emphasizes just how to think about interacting with these families and just some ways to try and understand that they're not quite like the first-time parents, right? And the things that they're going through. So having a very real understanding of the limitations of our own knowledge and what we know about some of these medical complexities. Some of these families have traveled the states, the nation, they've traveled the world to try and find cures and solves for their kiddos' problems. So sometimes you're talking to that parent, and that's as good as talking to another healthcare provider. They are super knowledgeable. So just kind of that recognition of where our knowledge ends and where they might have knowledge that we don't have is important. I can't emphasize enough that I think a lot of it comes back to just being a good human being and having a ton of empathy for families and what they're going through. And it can be hard, right? Because in the emergency situation, we can have those contentious meetups with families. They're frustrated, they are dealing with a lot of things, but if I can walk you through the week that they just went through, they knew this was a problem on Monday. They called the DME company. The DME company sent the wrong size equipment. The DME company says, you got to call the insurance company. They call the insurance company, who says, follow up with a letter to the specialist to get this done. They've been on my chart 24 times, and it all went wrong anyways because nothing got fixed. And then some snot-nosed 20-year-old from City EMS shows up and tells them how the world's going to work, and none of it sits well, right? And so they're just a little bit agitated and upset. Or even more scarily, the 20-year-old shows up and doesn't know how the world works, doesn't know how to help them. And so I think just trying to understand some of the stressors that these families are undergoing and how that maybe that tracks a little bit differently than some of our other families out there. I think a lot of ways, just good verbal de-escalation techniques in those situations is that, hey, I'm here to help your kid, but you know your kid better than I ever will. help me help them. What is concerning you the most? What do you see as a person who takes care of them every week? And see if you can't reconnect over the thing you have in common, which is trying to help their patient out. And a lot of times they just need somebody to listen, right? Like they have just been through the ringer this last week and they just need a listening ear a little bit. And so sometimes, obviously we have to do our medical job, but a lot of that scene management and that family management can come back to just good conversation with the family. There's really no way around the fact that for these kids, transport has to be tertiary care. This is, as we let off way back at the beginning, but you know, a part of the world that has arisen out of changes in healthcare, right? Like we have these super niche specialties that are really good at this, and they exist because of EMS. Like these are mutual industries that have grown together, right? Like I'll never forget, just not that either emergency doc in here would have ever done this, but like I recall a little bit in my early days, like you showed up and they're like, "What are you doing here? Like, why are you here?" Well, it says emergency department. I brought you a sick patient, right? But I'll never forget the first time I went to a talk from an interventional radiologist, and he was like, "I have a job because of you guys, right? Like it used to be stroke patients like laid on the floor and died in their houses or were permanently disabled. But because we have a group of people in industry that is willing to get them to me in a set amount of time, and I can do things for that." And so that's just when I'm thinking about medically complex patients and the specialty procedures that they need. Somewhere when you pick this patient up, there is something they need in the healthcare system somewhere that will save them from this emergency. And how do we think about what their needs are and how do we most efficiently deliver them to those needs? These kids are just another subset of that category. They have a cardiothoracic team somewhere who knows them very well, who has endless diagrams and 3D models and everything of their heart and know how to treat them. And so we just got to figure out the best way to get them to those people. So to just kind of round this all out, probably a little bit basic for a critical care class, but I mean, interviewing families, get down to trying to figure out what is this kid's normal emergency? Are they an acyanotic emergency or a cyanotic emergency? Are they a blue kid or a pink kid? Do we have future planned interventions, or do we think, did cardiothoracic kind of leave it with, hey, we think this is pretty good, follow up with us every 6 months for an echo? Are they still on meds? Do they still have oxygen supplies at home? What's food intake and weight gain or loss been like? And then just it's part of the reason I picked the hypoplastic left, but just that understanding of like Doc Finney said, like maybe we don't need to know all of the exact surgeries that are happening, but I think the concept that these kids undergo stages of repairs and their level of sickness changes throughout those stages is a really important concept for these kiddos. And don't overtreat off that isolated SpO2. And by definition, these kids have a bad pump. And if it is tacking along, it is going to grow increasingly inefficient. So as part of your basic treatments and interventions, eliminating any unnecessary tachycardia, any environmental tachycardia, let their parents hold them, give them their favorite toy, put their favorite show on the iPad, whatever it is, see if you can eliminate the bright siren and light tachycardias. If they got a fever, if they're sick from something else, they got the flu or whatever else, we want to treat with antipyretics to reduce the fever, sedatives as necessary, oxygen to maintain their baseline sats. In a perfect world, somebody is sitting there with a plan, or STARS plan says this is where this kid's supposed to be on their sats. But even if you don't have that, if you have an unknown, unrepaired CHD, just assume 75 to 85% is kind of their normal thresholds. And that you can absolutely give them fluids, just do it in small little boluses and check those known sites for fluid backup in between.